main speaker of the day, who is Dr. Awad, who will be introduced by Dr. Michailidis today. Loisos.
Thank you, Dr. Almeida. So it's my honor to introduce Dr. Awad as our keynote speaker today. On the next slide, you can see Dr. Awad is Associate Surgeon in the Department of Neurosurgery here in Mayo Clinic, Florida. And his lecture today will focus on advancements in the endovascular management of cerebral aneurysms. He got his bachelor's degree with magna cum laude at the Arizona State University and his medical degree at the University of Arizona College of Medicine in 2015. He then completed his neurosurgery residency training at the University of Utah in 2022 and is now completing an endovascular fellowship here in Mayo Clinic, Florida. Some of the honors and awards Dr. Awad received throughout his career include a maroon and gold full tuition scholarship. And he has a lot of publications with high impact in literature and an age index of 9 on Scopus. So it's truly an honor to have you here today. Thank you for joining us today. And without further ado, Dr. Awad, take it away.
Thank you, Loisos. And Wala, thanks for presenting today. We're all excited and great to have you here. Please go ahead.
Thanks for having me. Can you guys hear me okay?
Actually, I think you have to kind of like work on the display settings because we can see your presentation mode. So if you can just invert the screen, I think.
I'm sorry, you cannot see my screen?
No, we see your slides, but we see the presentation mode, you know, the one that you can see the time and the presentation, etc.
So if you go up,
go up. Yeah, go ahead, Carlos. Tell them, please.
Thank you, sir. Yeah, display settings, then swap presenter view. There you go.
Is that better? Okay, great. Awesome. Thanks for having me. So you can see my mouse move here as well, right? I could use it as a pointer.
Yes, we see it.
Okay, perfect. Well, good morning. Today I'm going to talk about advancements in endovascular management. I apologize for all the non-vascular surgeons on the line. This is a little nuanced, but I think we can all appreciate the steady progress that we're making in neurosurgery. Cerebral aneurysms are not unknown to us, and they're relatively rare pathology, but they have severe consequences. Over the years, we've slowly learned the risk associated with rupture. And when we talk about the advancement in their treatment, it's important to understand where we came from. This is just a slide showing kind of the trends from the national inpatient sample of how aneurysms were managed. And you can see in the early 90s, we started to have a very subtle shift from open surgical management to endovascular techniques. And then you can see here that mortality rates for unruptured aneurysms dropped significantly throughout the years during that same time span. And then to a less degree, the mortality of ruptured aneurysms as well. Just a quick note here on this image, you can see that right around 2001, there was a sudden shift towards endovascular management. And that coincided with an important landmark study, the ISAT, which I'll go over in just a second. You can see that these trends kind of continued throughout the years. Again, here in 2001, the number of coiled aneurysms increased dramatically compared to the number of patients that were having open surgical clipping. And then this was true for both ruptured and unruptured patients. And then, of course, this trend continued throughout the late 2000s. So I mentioned the ISAT trial. This was a landmark study and kind of a gargantuan effort to try and answer this important question of whether or not coiling of aneurysms was safe, specifically in the ruptured setting. You can see this was a huge patient population, especially for a neurosurgical study, and they wanted to evaluate outcomes at 1 year and look at some of the safety profiles. So I won't go through all the details. I think we've all kind of reviewed the study on our own, but just to point out, the majority of aneurysms were in the anterior circulation. And the overall kind of general finding from the study was that there was a significant increase in the absolute risk reduction, which favored coiling compared to open surgical clipping. Another important question that this kind of helped study was, what was the risk of re-rupture in patients that were coiled? There was a lot of concern early on when aneurysms were being coiled and whether or not they were adequately treated and what the re-rupture rates were. Since this was a new technology, those things kind of were not known. And this kind of slide down here, or this image down here, demonstrates that in the endovascular treatment group, there was a slight increase in the re-rupture risk even after coiling was performed. However, in the surgical group, this risk was all up front while a patient was waiting to be clipped. And this probably represents a difference in the timing of treatment. I assume that maybe it was easier to kind of mobilize teams at night from an endovascular standpoint, as opposed to taking somebody to the operating room. So I suspect that some of these patients re-ruptured as they were waiting to go to the operating room. Despite this slight increase, overall, there was no significant difference in the amount of rebleeding events at 1 year. You can see those numbers there, 45 and 39. And then the surgery was associated with a slight increased risk of epilepsy or seizure, kind of associated with dissections. So after that study was completed, there was a paradigm shift towards kind of coiling, and endovascular centers started to kind of pop out all throughout the United States and also throughout the world. And it was all kind of started by this idea of having this detachable coil. The detachable coil is, of course, developed by Dr. Guglielmi, who has an amazing origin story of development. I mean, he started this as a medical student, kind of developing the techniques and ideas of how to treat aneurysms specifically from an endovascular approach. And he just kind of continued the development throughout his career, eventually coming to the United States, where he completed the first detachable coil in an animal, and then of course in humans. The basic design of detachable coils is these platinum coils can be programmed. They're a material called nitinol, which retains memory. And so you can form these loops, and they'll retain these forms when they're kind of expressed outside of the catheter. And so these loops can be programmed in different sizes, for example, 3 millimeters or 5 millimeter loops. And they'll always take that shape when they're deployed, as long as they're not too restricted. And then there's an attachment zone where the platinum kind of alloy is attached to a stainless steel delivery wire, which is what we use to deliver the actual coils to the aneurysm. But the real magic and the hardest part kind of in the development of the coil was finding a mechanism of detaching it. You have to remember that we're kind of putting these coils up in the brain, but our hands are always working down at our access site, right at the groin or at the radial artery. And so at the time, they didn't understand how they could do this. And so through his experimentation, he developed or realized in one of his experiments that he can get the platinum to rapidly dissolve through a process of electrolysis when you add a little current to it. So the entirety of the steel delivery wire was covered with Teflon to protect it and kind of ground it from the surrounding environment, except for the detachment zone. And then when you applied current down the stainless steel wire, the thin portion of it that attached to the titanium would rapidly dissolve in blood, and you would effectively detach this coil. And then that would stay retained within the patient. And that was kind of a huge breakthrough at that time. They already had some data that this titanium alloy was thrombogenic in nature. And so they knew that this was kind of the missing link. And then from there, further developments came along. This is a very simple coil. Today's coils are dramatically different. They're programmed to take on complex and 3D shapes depending on kind of the needs of the treatment. Coil embolization is kind of usually divided into 3 stages. The framing coils is usually first. This is where you first enter the aneurysm, and you want to create a large kind of complex that is going to support all the other coils that will come in the center. And so these framing coils have their own characteristics. They're usually stiffer, larger, and meant for support. And then you have these fill coils, which are generally softer, and they're good at kind of folding and collapsing in different shapes to try and occupy as much volume of the aneurysm. Then, of course, finishing coils are designed to occupy the last nooks and crannies, and these are usually the softest coils that you want to use kind of towards the end, and they tend to be the smallest as well. Since the inception of the detachable coil, there's been dozens of iterations from various companies, and they all have different characteristics, and they all kind of contribute a different treatment effect. And so oftentimes when we're treating aneurysms with coils, it's a combination of brands and coil types depending on the problem that we're trying to solve with that particular aneurysm. And through the years, they've even added different additives, coatings, and things like this to the metal to try and increase, thrombogenicity to get the aneurysm to occlude faster. But more importantly, coils were also an important advancement because they allowed us to combine them with other treatment techniques, and especially in different aneurysm types. The greatest advantage, though, with the coil to this day is that you can use it without the need for dual antiplatelet therapy, and that means that you can use it in patients with ruptured aneurysms, as long as all of the metal is confined to the aneurysm sac. Some of the disadvantages is that it was only limited to coils that were saccular in shape. That way they can trap the coils. And through the years, we've kind of developed this kind of ratio that we use to help guide us on determining whether or not a coil is going to safely stay within the aneurysm. We talk about a dome to neck ratio of around 2 or so being the cutoff. If coils do herniate into the parent vessel, obviously that creates a thrombotic risk. And it can be also problematic if they start to migrate distally to further branches. And then, of course, there's this question of what happens to the aneurysm after you coil it in terms of recanalization risk and aneurysm growth, and we'll kind of discuss that here in just a little bit. These are some examples of some of the outcomes. Obviously, B's a coiled aneurysm successfully treated, it's endothelialized, and the parent vessel is reconstructed. This is what we mean when we talk about recanalization or compaction of the coils. This can happen over time from the water hammer effect. And then D represents an aneurysm, which was effectively coiled, but the aneurysm itself grew. So this is an entirely new segment of the aneurysm. And then lastly, this represents a situation in which the coil mass has migrated through a weak point in an aneurysm. And this can happen even after the procedure is completed. So not during deployment, but days after the treatment. So these have all kind of been described in the literature, and now we have different ways of kind of mitigating some of these problems. One of those ways to kind of improve coil embolization is the use of balloon assistance. So we've had balloons for some time now, since the early 90s. Today, there's kind of two main balloons that we use, the Scepter and the Eclipse, and they're essentially used to help increase the safety profile of coiling. If you have an aneurysm that doesn't have a nice saccular shape, maybe it has a broad neck, you can use a balloon to help kind of create a large nest that's stable using a framing coil. And then you could put smaller coils that you'll be assured will stay in because that framing coil is nice and secure within it. The nice thing about balloons is that it doesn't require leaving any metal behind. Once you're done, you just deflate the balloon, you remove it, and you're only left with the coil mass. So you can keep the patient on a single antiplatelet agent or no agent at all. And you don't have to expose them to the increased risk of dual antiplatelet therapy. And then also, the cons associated with these is this is a foreign body kind of stopping or occluding the blood flow momentarily. So there is some risk of increased thrombogenicity along kind of the edges of these balloons. So just something to keep in mind. Sometimes when you inflate these balloons, they don't have the best response time. And so overinflating can cause ruptures, and that can happen directly through kind of mechanical effects of the balloon, or sometimes even just increasing the localized pressure within the aneurysm can cause ruptures. But for the most part, these have been an important addition to to coiling aneurysms. And they've been evaluated through a number of studies. Probably one of the largest studies that we have is a European multi-center trial called the ARETA, and this was a prospective database of over 1,000 patients, both ruptured and unruptured, treated with IO coiling or balloon-assisted coiling. And this has been an ongoing kind of release of data for several years now. I think they've released almost 8 studies from this patient cohort to answer a number of questions. And you can see here's all the patient data in regards of how many patients presented ruptured and unruptured and the patient size. The more important findings from the study is that at 1 year, they got adequate occlusion rates of about 92%. So above 90 in both ruptured and unruptured patients. And then they also wanted to quantify the overall risk associated with coiling when using balloons. And you can see here that some transient ischemic injuries did occur. Again, keep in mind that this was kind of earlier, using some of the earlier coils, and some of the technologies that we have now are a little bit more advanced and safer. And then intraoperative rupture rates were really low, 3 and 1.8%, even in the case of ruptured aneurysms. One of the important questions that the study hoped to answer was, what are the recanalization rates after you've coiled aneurysms? And that was summarized here. This data was released just a few years ago, and it shows that surprisingly, in ruptured cases that were coiled, the recanalization rate can be as high as 30% at 1 year. So that's an important consideration to think about when you're talking about follow-up for patients. Additionally, if you look at the unruptured rates, 25%. And then these are the remaining risk factors associated with recanalization of treated aneurysms with coils. You can see here aneurysm size, wide neck aneurysms were associated with increased risk of recanalization. And then, of course, location, the MCA was a risk factor for recanalization. Despite the recanalization rates, the rebleeding rate at 1 year was quite low, less than 1%. So these were mostly discovered because they were part of a trial where regular follow-up kind of was involved, but an important consideration to keep in mind nonetheless. Just kind of moving along, after balloons, there's a development of stents which helped assist with coiling wide neck aneurysms. This was an important adjunct because these remained within patients. They allowed for more aggressive coiling. So you can be a little bit more aggressive and not have to worry so much about coils herniating themselves out of the aneurysm. In addition, the metal across the neck provided some scaffolding for endothelial cells to come across and help contribute to the treatment of the aneurysm. And this is just an image showing different ways that we use stents to help kind of in this process. And then more importantly, they were used for this Y stenting technique, which allowed us to safely treat basilar and MCA type aneurysms. And you can see here we can deploy a stent within a stent and then come back with a microcatheter and then coil off these basilar tip aneurysms and MCA bifurcation aneurysms. Whereas prior to this, that was a really challenging aneurysm to treat. Some of the cons of using a stent or leaving any metal in the parent vessel, again, is using dual antiplatelet therapy to reduce the risk of embolic complications. And so this technique was kind of limited in terms of what types of patients you can use them for. Early on, this was just used for elective unruptured aneurysms. And then as more and more studies experimented with these, even in the ruptured settings, because you can tightly pack aneurysms, ruptured aneurysms with coils, it was eventually found that it was actually safe to use even in the case of ruptured aneurysms. I'll show that here. These are the two main stents that we started off with. This is the Enterprise stent above and the Neuroform stent. These are the two basic designs of how they work. You can have a closed cell designs where all the struts are welded together so that it's one continuous sheet of metal. The nice thing about this is they have strong radial forces, so they always open. And they provide a really good kind of framework for supporting a lot of coils within the aneurysm sac. One of the more important features of this type of design is that it's resheathable. So if you deploy too early or if you have some kind of complication during deployment of the stent, you can resheath this before it's fully removed. On the other hand, the Neuroform Atlas stent has this open cell design. So not all the struts are welded together. And actually when they come out of the catheter, they come out as almost like individual rings like this. And together they form a long tube. This open cell design makes them more flexible. They take angles very well. They take turns very well. So you can put these things just about anywhere. They have slightly weaker radial forces. So they're harder to use in smaller vessels where there's not as much room to open, but they work the same way. They help support coils above and below them, so that you can densely pack aneurysms. This is a study just to look at the differences in outcomes when using stent coiling, both in ruptured and unruptured aneurysms. I'm just going to go through the big points here. Immediate occlusion rates when using a stent were slightly lower. This is probably because people are being more careful in ruptured settings and they're not being as aggressive. And then there's also the thought that there's dual antiplatelet therapy being used, and maybe the aneurysm doesn't clot off as quickly. The more important is the occlusion rates after last follow-up was significantly higher, 74% compared to 61% when you're not using a stent. And that was at 1 year. And then similarly, recanalization rates were significantly less when you're using a stent. And again, this is probably related to having an increased packing density and also the flow diverting effects of the stent itself. And then of course, there's some increased vascular complications when using the dual antiplatelet, and then having more metal in the vessel is going to lend itself to having increased thromboembolic complications. Today, these are the more kind of advanced, newer versions of these stents, kind of similar in design, but each kind of have a unique niche that we would use them in. These smaller versions are specifically designed to be released in smaller vessels, but you can see here there's a large assortment that you can use. An interesting concept was combining both the balloon and the stent, and that's what the Comaneci essentially is. This is a retractable stent that kind of functions similar to a balloon. Essentially, you have these 12 wires that are all attached to the central wire at the base. And when it's released, it stays perpetually attached to this so that you can retrieve it when you're done coiling. The reason why this is more advantageous than a balloon is because this is a non-occlusive device. So when you place it, you can coil the aneurysm and you're still maintaining the blood flow in the parent vessel. Additionally, it's soft enough where it'll conform into the neck of the aneurysms. Because you retract this retractable stent at the end of the case, there's no need to put the patient on dual antiplatelet therapy, which is an important consideration, like I mentioned in patients with ruptured aneurysms. The Comaneci was trialed in a series of patients with ruptured aneurysms, 118. You can see these are the characteristics, a combination of anterior and posterior circulation and aneurysm size. So most of them were under 10 millimeters in size, like most of the studies today, but there were quite a few larger lesions. And overall, after the study period of 1 year, there was a complete occlusion rate of 66.9%. The reason why that doesn't sound very impressive is because the goal in these patients specifically was safely treating the ruptured aneurysm without having to use dual antiplatelet therapy. So even though this number doesn't sound great, it's about 70% of the time you can safely secure an aneurysm, and then afterwards you can come back and treat with a more definitive therapy once the bleeding risk is significantly reduced. And that's essentially what they did in this study. If you look at the outcomes here, about 37% of the patients required retreatment. They did that at the end of the trial using a combination of flow diverters or additional stent coiling, but this time they were allowed to kind of use dual antiplatelet therapy. So the goal of this stent was really just to get the patient through the risky part of the treatment, and then you can go back and deal with a more definitive therapy. The stent itself has been associated with some thromboembolic complications. When they're using the stent in this study, they did use some heparin during the procedure, but nothing else, and that's likely what this was attributed to. 7 patients had thromboembolic events. All 7 of these patients, you could visually see a clot forming on the stent in the middle of the procedure, and those patients were immediately treated with ReoPro to try and break the clot, but unfortunately 3 patients persisted with a deficit. I'm just going to move a little bit faster here for the sake of time. The next kind of category that we get into are flow diverting stents. These are fundamentally different than any of the other treatments we've talked about. They're designed to kind of reconstruct the parent artery and treat the aneurysm without any aneurysmal manipulation, which is a huge shift in the way of treating aneurysms. The downside to using these flow diverting stents is there's a significant amount of metal that's left in the patient, and so they require dual antiplatelet therapy. But just like stenting, you can support aneurysm treatment with adjuvant coils. The very first device, of course, was the pipeline embolization device, and it covers about 30 to 35% of the vessel, and that's why you have the dual dual antiplatelet therapy. Originally, this was designed to treat wide neck aneurysms that were deemed too risky for surgery. And then over the years, obviously, the use and expansion were allowed as the safety profile was known. Since then, there have been numerous studies looking at how effective it is, with occlusion rates kind of ranging from 75 to 90%, depending on how much time there was to follow up. And then more importantly, complication rates come down over the years. I'm just going to skip some of these trials. These were using the original pipeline embolization device, just demonstrating the safety and efficacy of the device. This is just a quick example of how effective these can be. It's really good at repairing the additional vessel. This was a patient that we treated, and you can see here, this is a partially thrombosed giant aneurysm. The parent vessel is completely diseased. Laying down a flow diverter along this diseased segment, at follow-up, you've got complete reconstruction of the original artery, and there's only a small hint of the aneurysm there. Again, this is a complex fusiform aneurysm with a distal MCA, very challenging aneurysm to treat. We did this during my my fellowship year, and when we came back at the end of the year, completely resolved, and the vessel's completely reconstructed, all without being in the aneurysm itself. So pipeline. The original pipeline was really clunky and difficult to use. I never actually deployed one. It was on the market for a few years. It was quickly replaced by the Pipeline Flex. The Pipeline Flex just added some modifications that made it easier to deploy. With these devices, they don't have a lot of radial force. And so the Pipeline Flex just re-engineered the way that this comes off the wire so that it opens more readily. The detachment device was made easier to understand on the radiographs. And then they added the safety line or the safety coil in front of the device. That way you can track it within the vessels without causing a perforation. The original version didn't have the soft coil. One of the complications was this tip would perforate through the vessel that you were treating. The Flex was used for about 10 years. It was very effective, and they had remarkable outcomes. Eventually, it was replaced by Pipeline Shield. This has been on the market for about 2 to 3 years. Effectively, all pipelines used today are Pipeline Shields. It's the same exact device, except they added a coating that helps prevent or reduce the thrombogicity of the device. And this is just a quick sample showing of how effective this is. Here's the original pipeline. Here's the pipeline with Shield. And this is a human blood flow model. So they put human blood in circulation, and they allow this to circulate for some time, and they demonstrate how much platelet activation and thrombin activation you get. And then here you can look at the electron scanning microscope, and you can see it's amazing how much how effective that Shield technology is. Compared to the original designs. Fred is a competitor flow diverter. It was the second device to be approved in the United States, and this just demonstrates how much increased thrombicity there is compared to the pipeline embolization device. So this is currently what we're all using, and I'll talk a little bit more about that. The next iteration of the pipeline is the Pipeline Vantage, and that's kind of a complete reworking of the original pipeline. I'll discuss that in just a second. I just want to mention kind of what motivated Pipeline Shield was this idea of slowly moving away from the need of dual antiplatelet therapy. That way they can expand the treatment to ruptured cases as well. This is the largest study on a Pipeline Shield. All of them were with dual antiplatelet therapy, over 200 patients treated. And you can see here that at 1.5 years, an occlusion rate of 92% was achieved, which is kind of amazing. And more importantly, a very low complication rate associated with the device. This just demonstrates that treatment is progressive in nature. At 6 months, it's about 80%. At 1 year, you kind of achieve that 92% mark. The next study was a study looking at using Pipeline Shield in ruptured aneurysms without dual antiplatelet therapy. So patients were only were put on aspirin. And because it was a pilot study, is a low number of patients, 14 patients, you can see here that several of them got EVDs prior to treatment. They didn't have exact protocols down. So initially, a lot of the patients were heparinized, and the use for heparin was that, well, we can always reverse it if something goes wrong. And then they were treated. Unfortunately, in the first 5 patients, the heparin was continued post-treatment. Again, initially the plan was maybe to do that for a day or 2, but that was associated with complications. And so for the remainder of patients in the study, they turned off the heparin after the treatment was completed. Overall, they still had a good occlusion rate using aspirin only, but still they had about a 7% complication rate, which is a significant jump compared to where you are with dual antiplatelet therapy. That's what this study is. This Canzano study was a meta-analysis of using pipeline in the setting of dual antiplatelet therapy, and they were comparing it to this study, which used only aspirin alone. And then you can see here the complications that they had. Again, were mostly associated with patients who were maintained on heparin post-op. And then the remainder of the patients, they switched to aspirin alone. So this is once daily aspirin, and this is twice daily aspirin therapy. And it was pretty well tolerated. So that's slowly kind of being expanded into a larger study. In the meantime, Medtronic is developing a new device, the Pipeline Vantage. This is a complete reworking of the way that the pipeline was constructed initially, with the hopes of achieving improved opening of the device and decreased thrombogenicity. You can see here they're braided wires in the original pipeline. In the Pipeline Vantage, they do this wire pull-through technique where they have the chromium wire on the outside, the titanium on the inside, and this allows for a better treatment effect. And here's a study in a rabbit elastase model showing the Flex, which is the one that we're all using now, versus the Vantage. You can see that they got greater occlusion rates at the time of follow-up, which was 90 days in this study. And then also you can look at the thrombogenicity decrease. So here's the Vantage, the new pipeline. There's almost no thrombin on the metal. And when you compare it, it almost looks like there's no device in the patient, which is kind of amazing. So the next question is, what happens in humans? The very first trial was just released. It was about 60 patients. All the patients were treated, had aneurysms. I think there were only 6 of them in here that were, 3 that were ruptured, but everybody was on dual antiplatelet therapy. I'm just going to jump to the results just for the sake of time. And you can see here, 3 patients presented with subarachnoid hemorrhage. And then the outcomes basically showed they also evaluated kind of the ease of use, and everybody agreed that it's a very easy device to use. And the complete occlusion at 7 months rate, which is about 78%, which is comparable to where the Pipeline Shield was. And they're confident that at 1 year, this will jump back up to the 90% that we saw prior. There was an issue with the study in that they were surprised with how many times they had to angioplasty the stent. And the authors of that study mentioned that they changed the deployment mechanism as a result. So they've got another round of trials now before we see the Pipeline Vantage. It'll be interesting to see how this plays out. But again, this is part of that steady march to move away from using dual antiplatelet therapy. Quickly, this is that FredX competitor. This is different than the Pipeline in that this is a stent fused with a flow diverter. So it's a ton of metal, and it has the advantage of opening very nicely because that stent is there. It helps it open, but it's associated with higher thromboembolic complications. This is a summary slide showing all the different flow diverters that we have on the market. They all have very comparable occlusion rates. The main difference is complication rates. And you can see Fred, that's the one I just showed you, is kind of main issue right now is occlusion rates. And because of this, they're all moving to adaptive technologies to try and add drugs or medicines to the metal itself to try and reduce the thrombogenicity. And those devices are all kind of slowly coming out. That's what the FredX represents, is the new version with an agent to help reduce the thrombicity, but we don't have any large studies to show that it's safe. Again, these are the other ones that are on the market. Sorry, I'm just going to keep going here just because we're running out of time. The last category of endovascular options that we have are the intrasaccular flow disruptors. The Webb device was the very first device released to the market. This is like a metal mesh that gets deployed within the aneurysm sac. Again, if deployed correctly, the advantage here is you only have to use aspirin instead of the dual antiplatelet therapy. The original design was a dual layer. This was very cumbersome and difficult to use, so they all switched to a single layer, either looking like this in this kind of square shaped or a more spherical shape, depending on the type of the morphology of the aneurysm. A number of studies were completed to evaluate the efficacy of use. These 3 large European studies were combined into a single meta-analysis that had 168 patients, with them looking mostly at safety. At 2 years, you can see mortality was about 5%, morbidity was 1.4. This is kind of in line with the flow diverter data. But if you look at the efficacy rates, that's some more concerning numbers. their overall occlusion rates were significantly lower compared to the complete occlusions of flow diverters here. This is almost 50%. And this is kind of related to having a high number of neck remnants. So when you include all the neck remnants, they kind of categorize this into an acceptable occlusion, which is about 80%. And that's kind of summarized here. So complete is 51, but when you combine them, it's about 80%. The WebIT was the very first web trial in the United States. It had very similar results, complete occlusion at 1 year at 51, but then kind of the acceptable range, again, when you combine the small neck remnants, was 84%. Just a word on that, that neck remnant they think could be a result of kind of the grading system that's being used. So just to kind of briefly mention some of these other intrasaccular devices, which I thought were kind of interesting. This is the Medina. This is a product by Medtronic. This is a large coil mask kind of welded to a coil, and they come onto these little, like, they call them like flower pledgelets, and the coil that it's attached to kind of takes the shape once it's fully deployed within the aneurysm sac. There's only one study looking at its efficacy and use right now because it's early in development, but they are able to achieve an 80% adequate occlusion rate at 18 months. However, it was associated with 3 permanent neurologic injuries and 1 death, which is kind of a big deal for this category of devices. The Contour is another device very similar, except it's not designed to occupy the entire aneurysm, just designed to reconstruct essentially the neck. And then the Luna is a comparable Medtronic device. They're all summarized in this study here. You can see they all have very similar occlusion rates, but the main issue with these devices is that, again, really high thromboembolic complications compared to some of the available options on the market. So the problem with having a lot of technologies, it's difficult to kind of assess them effectively. And that's kind of the situation that we're running into now. Every week there's a new device, a new idea, which is great, but again, it's difficult to know which option is best for the different situations. Additionally, these new devices are not cheap, and they contribute significantly to the cost of treating aneurysms. And then also it's challenging to know how much of it is the end device versus the delivery system, meaning the guide catheters, the microcatheters, all the additional support you need to kind of complete the treatment safely. So I'm sorry, I know that was fast, but we had a lot to cover. The key concepts to take away are kind of coils were revolutionary, and this is still kind of our mainstay option for ruptured aneurysms. It's important to consider recanalization rates with these, though, so you have to keep close follow-up on patients. Flow diverters are certainly a game changer, especially in the anterior circulation, and it's a balancing act when it comes to the dual antiplatelet treatment. But the important note here is that there's a steady march kind of away from that to try and develop devices that are less thrombogenic, and I think that's what's coming next. And of course, this is the one wild card, the intrasaccular flow diverters. It'll be interesting to see what happens to these in the next 5 years, whether or not they're adopted or not. They're early in their development, and I think that's why they're having a lot of problems with complications. But I think they serve as an important kind of treatment options for some of the MCAs and basilar tips that we have to treat at these bifurcations. So I just want to say special thanks to the vascular team, of course. It's been a great year so far, and I look forward to rounding it out, and I'll take any questions.
Thanks, Walla. A very nice presentation, and I think we jump into questions for the sake of time. So I see Dr. Lee has his hand raised. So
yeah,
James.
Thanks for such a great talk. So when an institution is bringing all these like new devices, and maybe you or someone else can speak to it, what's the biggest hurdles of bringing something new in, like something like a stent electrode or any other new inventions for these? Because I can imagine, like, besides the IRB or the research end, that there's like other hurdles in terms of patient care that, that can kind of block this or bottleneck it.
Yeah, I think the biggest thing from what I've seen is just cost of having these products on the shelf. There's different economic models for keeping products in hospitals. There's models where the hospital has to buy all the equipment up front and put it on the shelf. And there's models where you pay after you use. But the point is because there's so many options, it's hard to have everything on the shelf. And that tends to be the biggest hurdle. And just for everyone's edification, in private practices, a lot of times you don't have all these options. A lot of times they have exclusive deals with a single provider, and you're going to use only Stryker products or only Medtronic products. So even if you like the outcome of certain device, there's no guarantee that you can get it in your hospital. And that's why it's important during training that you get kind of exposed to as much as possible. That way you're facile with anything that's coming down. And I don't know if anybody has anything else to add.
Excellent review. This was a really good review for current techniques and what we're using, and it was a very good summary of the evolution as well. So nice job. I think one more question, JP, if you want to go ahead.
No, I mean, I think that Dr. Vargas has his hand raised, and I think we use that as our last question for the sake of time. But Dr. Vargas, please go ahead, sir.
Thank you. Thank you for the revision. Just one question for all of you. What would be the role of surgery in vascular topics as aneurysm things? Because I see here in Colombia, and of course I imagine in the United States, that most of the residents don't have enough exposure to open surgery for vascular treatments. What we're going to do? What would be the solution? Or we need to say just forget the surgery, only endovascular is the way of treatment of aneurysm, for example. What is your opinion on that?
Yeah, I mean, I think that's an important question. Honestly, I prefer surgery. I enjoy it even more than endovascular, to be honest. But it's difficult to find indications for surgery nowadays. I think there's still some situations where you've got branches coming off of aneurysms, for example. They still require highly specialized surgical techniques like bypass and clipping and whatnot. But in terms of how do you fix that from an educational standpoint, that's a tough question. The issue of center of excellence have been brought up, where you have specialized centers that are only going to teach open vascular cases, and it's up to our hospital networks to refer patients to them when that's the case, and only specialized surgeons will do them. I'm confident though that in the future we're going to have an endovascular option for everything, and we're close to that now. But I don't know, Dr. Talk, if you have anything to add from an attending perspective.
I'm a little bit more optimistic on the surgery side, and so definitely everything we're doing basically, but I don't see that the surgical skills are out yet. I still see many aneurysms that are much better treated with surgery, in particular when they're involved branches. I don't think we have the device that reshape those. And unfortunately, I've seen the interest from our neurosurgeons decreasing significantly, to the point, yes, unfortunately, it's rare to produce a resident who's competent in clipping out of training without a fellowship. So those are the facts. So I encourage residents to show more interest and be more interested, because if you're not interested, somebody else is going to do it. For patients, unfortunately, I've seen many patients where the expectations have lowered significantly, to the point, oh, we're just going to accept stroke because we can't save this branch. No, you can save this branch. You can do a bypass on it and save it. It's a very simple technical procedure if you train yourself to do it. So I think definitely we are almost falling behind as a specialty on catching up on what needs to be done to fix those patients. And I hate to see that. I mean, if we look at Europe, basically, there's only a few centers who still offer surgery, and suddenly you start accepting this as saying, oh, this is a common complication. But no, it should not be the case. So I think we definitely have to continue looking for the best interest of the patient instead of migrating to the easiest pathway, which is endovascular. So now we need to train and continue to train future residents to take care of those patients.
Yeah, I just wanted to echo that. I think Dr. Vargas brings up a great point, and I just echo everything Robbie said there. But as an endovascular specialist, I think the classical one that we struggle with is MCA aneurysms, which are highly dysplastic or have big branches coming off. And so that, that area, I presume, is very accessible for the surgeon. And, and I can't stress how important it is to have a excellent neurosurgeon, like Dr. Talk, Dr. Fox, available to take care of these tough cases and to have excellent outcomes. I think a high-level neurovascular center will always rely on the neurosurgeon to handle these for either, excellent clipping or bypassing. So, but training, as I agree, is an issue to have, and how to develop that expertise. I think that's a very, very tough question. But thank you very much, and I appreciate everybody's collaboration.
Well, with that, it's now almost 8:15 already. So thanks very much, Walla, for the beautiful presentation. Thanks everyone for joining us today, and see you on Friday and then next week as well with more sessions. Have a very good day. Bye-bye.